Welcome to the THOR Table of Knowledge podcast, where we dive deep into the groundbreaking world of trauma care, hemostasis, and oxygenation research. A special thank you to our sponsor, Velico, for their support. Velico is revolutionizing trauma care with their innovative frontline ODP spray-dried plasma system, with the goal of empowering blood centers worldwide to produce dried plasma for transfusions.
Good afternoon. I'm Andre Kapp, and I have with me today Andrew Beckett, trauma surgeon in the Canadian Forces, and a good friend and collaborator over many years as when we were co-chairs of the NATO Blood Panel together. Now I have left him in charge of the NATO Blood Panel, and he's doing a great job. So we're going to talk about bleeding and resuscitation on the battlefield and in the civilian world as well, where Andrew is a trauma surgeon at the University of Toronto and St. Michael's Medical Center in Toronto. The really thorny question that we're going to deal with today is non-compressible torso hemorrhage and what we do about it. We've spent a lot of time thinking about resuscitating these patients and giving them blood and trying to get NATO ready with this problem. But at some point, we also need to tackle hemorrhage control. So one of the things that the new technology that has been developed, reintroduced, we'll say, from its origin in the Korean War in the 1950s, is this concept of endovascular intervention to control bleeding. So with that, why don't you describe for us what the new technology is, Andrew, and where it's going?
So simply put is the Reboa is an endovascular tourniquet in the aorta where we can put a catheter up the aorta through a large vessel in the common femoral artery, and then we can blow a balloon up and we can stop distal blood flow. And this idea has been around for a long time. And, as you mentioned, it was started in the Korean War by Carl Hughes, who published a couple cases on that by inflating a balloon in the aorta and stopping distal blood flow. And so, the technology's been around for a long time. And also the idea of, occluding blood through the aorta, it's something we've used in surgery for, a very long time by external compression of the aorta. We're just stopping the flow intraluminally in the vessel. So the new technology is coming for Reboa, was first brought about from the wars in Afghanistan and Iraq, where the big problem of non-compressible torso hemorrhage came to light, particularly by a paper by Brian Eastridge of Preventable Death on the Battlefield, showing a large number of potentially salvageable casualties could be saved if you could stop that bleeding into the abdomen and the pelvis. And then further, Johnny Morrison, he took a look at patients who may have been potentially salvageable with Reboa, and he found it's about 1 in 5 patients that were potentially salvageable may have been, those deaths would have been prevented with Reboa. And that really got me interested in the Reboa programs, particularly the prime device that was being reintroduced into the U.S. And,
Actually, so speaking of the prime device, so what is it about, what's new in the technological space? Because it's not just a simple balloon anymore, right? They've really made some innovations to make this more usable and potentially safer use, right?
Yeah, exactly. And the new catheters, the balloon technology is, really evolving. The balloon technology is not just a simple compliant balloon anymore. It's a semi-compliant balloon with these little wrinkles on it, almost like a prune that allows blood flow to go around through the wrinkles. So you have this really elegant control of the blood flow, allowing for real, true, partial Reboa. So that's really the new generation in technology. It's coming out this new balloon technology for partial Reboa. And also you can manage it very elegantly using the above the balloon pressure through integral art line and through your sheath pressure. So you can really tell, you can separate the problem. You can perfuse the brain and the coronaries with a certain blood pressure, and then, decrease the pressure head in the abdomen and the pelvis. So you've got this really elegant control of bleeding for the polytrauma patient. So you're maintaining that perfusion to the brain, but you're stopping the bleeding that's happening in the pelvis. So it's a really elegant technology.
So what's achievable so like, let's say you get a patient comes in with a systolic blood pressure of like 80, who's bled, maybe 40%, 50% of their blood volume.
Right.
and you insert this Reboa catheter. Um, First of all, maybe you can describe a little bit kind of where you inflate this balloon. But let's just say, you get it into the right place and you inflate it and it's got this partial blood flow. So what's a typical in that situation blood pressure above and below the balloon? Like how much distal flow is there really?
So, you get above the balloon pressure, you're targeting a systolic blood pressure between 100 and 110, just, to normalize the flow to the brain and the coronaries. And then distally, if you're really aiming for a partial, but a pressure of about 50 over 30. And you're placing the aorta in the supraceliac region of the aorta. So you're, limiting blood flow to the kidneys and the bowel, but it's partial. And I would say, Reboa is an adjunct to resuscitation. Everybody's going to try to use blood products first to resuscitate the bleeding patient, especially with non-compressible torsal hemorrhage. So, it's an adjunct to your resuscitation. And in my experience with this, this partial Reboa, it's really interesting because what the bowel really doesn't like is the no flow to the bowel and then massive resuscitation, this on-off effect of complete occlusion and then reperfusion of the bowel. And that really gives you ischemia reperfusion. Yeah, it gives you a really massive shock bowel and their abdomens are hard to close. So just in my anecdotal experience, the bowel seems and the kidneys seem to tolerate that a lot better than complete occlusion and then full reperfusion, and you get this massive ischemia reperfusion pattern of bowel edema, etc.
Now, for our friends out there who may be less familiar with the technology, if they've ever been in a cardiac catheterization lab, you're placing balloons and stents and so forth under fluoroscopic guidance the whole time. But Primetime did some innovative work to help people, figure out where to put the balloon without having to use fluoroscopy, as I understand it.
Right.
Can you talk a little bit about the different zones and how they kind of size the catheter?
So there's 3 zones they have. It's really the zone 1 is from your left subclavian artery to the celiac access. Zone 2 is from your celiac to your IMA, and then your zone 3 is your IMA to your the bifurcation of the aorta. So those are your 3 zones. And also they did measurements in many different cadaver models and anatomical models, including looking at CT scans. And so most adults, for a zone 1 placement, it's going to be at 46 centimeters, and for the zone 3 is going to be 28 centimeters. But I can say with the new technology, because it's partial, it maybe really doesn't matter exact placement, because we've seen a lot more placement of zone 1 at partial than people trying to do zone 3. I always exclusively do zone 1 placement now, and because I can put it on partial and I can, and that seems to work well for any injury below the diaphragm.
So really, you don't need fluoroscopic guidance or even ultrasound. You can do this blind.
Yeah, I mean, I think, it's nice to have a chest X-ray just to confirm placement. It hasn't done gone anywhere it shouldn't have, but you also get a feel for the catheter going in if it's looping or something. As well as, as your skill level, it's like anything surgical procedure. The more cases to do, the better you get, and the less complications you have. And so, the Primetime folks have been doing a study about the learning curve, and it's really after 5 cases, you start really seeing a drop in your complications and any issues you're having. So it's just really it's a user familiarity and skill set you're building, and similar to other surgical things like laparoscopic cholecystectomies.
So, as the company and other companies, right? Because there are other products out there, and maybe you can just touch briefly on some major differences.
Yeah.
But as they've been developing these technologies, it's kind of hard to do really well-controlled clinical trials because it's kind of a moving target as all of this is happening in the last couple of years as they innovate and really make the things more usable and safer.
Yeah.
Can you talk a little bit about, first off, maybe some of the different technologies that are available besides the Primetime device, which is kind of like the original, quote, new Reboa, and then And then maybe we can start talking a little bit about how the clinical registries are building, and we can get some sense of how the clinical data is turning out.
Sure. Prime Time right now, they are really going forward with their partial Reboa catheter. It's called the B2 balloon now. That's the semi-compliant wrinkly balloon. They still have the older legacy generation of the Reboa Plus, which is a compliant balloon, which is basically the compliant balloons are like on-off switches. It's either your full occlusion or there's no occlusion whatsoever. So, and there's Frontline's Cobra, which is in the marketplace. It's the benefit that the Cobra catheter has. It's a smaller size sheath that needs to be placed. So it's a smaller catheter. So definitely better for smaller patients, maybe less signs of vascular access complications. But it lacks the integral art line technology, and it doesn't have the partial balloon technology. So there's other companies on the market too. Looking in the Norway, I think there's a company out of Norway. There's in Europe, there's some companies, and balloons have been used as particularly in the obstetrical community for decreasing a peripartum hemorrhage. Also, the vascular surgeons, they use a large amount of the coda balloons for aortic rupture. So there's various different balloons on the market, but it's really just in the trauma space. The two main players right now are the Prime Time Reboa Plus and the P Reboa Pro, and then Cobra's Frontline's Cobra catheter, which is as I said, a smaller compliant balloon.
And they're primarily used in trauma because of the sort of pre-sizing thing, no need for fluoroscopic guidance, right? So yeah, in the obstetric space, I know that they're used quite extensively, for example, in planned complex placental disorders like placenta accreta or freta to prevent major hemorrhage. And I understand that in the military context, one of the ways in which these catheters have been used downrange is to buy time, basically in sort of very forward surgical settings where you may only have one operating bed. You got a patient on there, you need somebody with hemorrhage control, even if it's just, buy you 20 minutes while you clear the first patient or so forth. How do you see adoption, for example, in the Canadian forces or perhaps other NATO forces of this technology, and how do you think that will help?
Well, I think it's a part of a mature trauma system. This is a way of buying time to triage your patients and then move them to where they need to go. And I can see this technology being used that you're at a stabilization point, or you have a Roll 1 facility. You have patients coming in, but you don't have the adequate resources for damage control surgery. So a very competent operator can place, particularly the P Reboa Pro catheter. Place it in zone 1 and then transfer the patient for a surgical facility. Because really, the data coming out from the Prime Time Prompt study is looking at zone 1 placement. You can leave it up there, 2 hours. Again, this is just emerging data. I personally have had the P Reboa Pro catheter up for 3 hours. And so this is the partial, yeah. So you have time to triage, treat, and transfer the patient to where they need to go for their for their definitive hemorrhage control. And again, this is an adjunct to your standard resuscitation with whole blood and other blood products.
So these products seem used in ongoing conflicts like in Ukraine or in Israel?
So in the Ukraine, there's a DoD funded trial. It's a prospective trial. It's very hard to do prospective trials or any type of good trials in active combat, but they are collecting data on the movement of patients. And I know Johnny Morrison's group, they're coming out with a paper, publishing a case series from the Ukraine, showing that it can be done in a Roll 1 facility and then transferring the patient to Roll 2 facility for their definitive care. So they're showing it is possible, and I really believe that P Reboa Pro will find a place in NATO and Western militaries' toolbox for the control of non-compressible dorsal hemorrhage.
And it's really the only thing on the market right now for non-compressible hemorrhage, right?
And non-compressible dorsal hemorrhage is a wicked problem, and trying to solve it is like really one of trauma's moonshots. Like, how do we solve this problem? And, it's one of probably the leading technology that has the most promise to deal with this problem.
Well, great. Well, eventually, I'm sure between blood-based resuscitation, shock drugs, and Reboa, and buying us that time that we need, we'll be able to treat these patients much better. Well, thanks for that great overview of the topic, and look forward to hearing more about it as it continues to mature.
That's a wrap for this episode of the THOR Table of Knowledge podcast. A big thank you to our sponsor, Velico, for supporting the advancement of trauma care. Their frontline ODP spray-dried plasma system is paving the way for blood centers globally to produce potentially life-saving plasma for transfusions. Check out our website, www.thornetwork.com, for more podcasts, and join us next time as we continue to explore the cutting-edge science of trauma, hemostasis, and oxygenation. Until then, stay safe and stay informed.